Hello, I'm Sarah Day, Policy and Research Manager at the HFMA, and you're listening to HFMA Talk, the podcast for NHS Finance. This episode is a conversation between Sanjay Agrawal, consultant in respiratory medicine and intensive care at University Hospitals of Leicester NHS Trust, and Caroline Clarke, Group Chief Executive of the Royal Free London NHS Foundation Trust. Both have worked together regularly through the HFMA, and this was a chance for them to catch up and discuss what they have both learned about their trust, the NHS and themselves through the pandemic. So let's join Sanjay and Caroline for a conversation that encompasses the NHS of the future, the politics of the COVID-19 response and pies.
Okay, hi Caroline, how are you doing?
Hi Sanjay, I'm good. How are you?
Yeah, I'm okay. I'm good. It's a really nice opportunity to chat to you because I think what's really nice is the two of us sort of do different jobs, but we do the same thing as well, right? We both are in healthcare. And so one of the things I'm really interested about is understanding what's going on at the top of the organisation. So for me, my hospital in Leicester, we get these great communications and we get an idea of what's going on. We probably get to know enough of what's going on without having to live it too. But you're living it. And I imagine you have to sort of do daily sit reps nationally and gather all sorts of data. So I was just curious to know what is it that you're sort of immersed in with all of this?
Okay, so shall I say a little bit about how we're organised and kind of who does what? And it's really difficult, isn't it? Because in life generally, some people kind of live the film and some people live the stills, and you've got to kind of get a balance of both. And if I'm you've got to sort of constantly put yourself in someone else's shoes to work out what would be useful. So we're our film is very, very sort of daily and almost hourly rhythm. So quite quickly, we did what lots of other hospitals have done, and we set ourselves up with a kind of daily gold call, and we have something called Gold Command. And in fact, our Gold Commander is one of my site's chief executives, is a woman called Kate. So Kate runs our biggest site, the Royal Free Hospital. We've got three main hospitals, and so she was our emergency preparedness officer. So she's very just switched on about this stuff, knows how to run an incident, knows the kind of considerations that you need to take, and knows about kind of pandemic planning. So she was the obvious person. So and then her team was how to kind of backfill her day job. So every day we get on a call at 12 o'clock and we discuss all the stuff you'd expect us to discuss. So, we always start with some data points. So how many patients have we got in? How many patients have we got in ITU? How many patients have we got ventilated versus on other forms of assistance? And that's going down. I'm sure it's the same for you now. It's stabilised a while ago and now it's going down. And we're starting to see patients presenting with illnesses other than primarily COVID, although there's quite a lot of comorbidity going on. So a lot of my clinicians, I'm sure you're seeing this, are saying, God, I'm seeing stuff I never saw before, or I'm seeing stuff that I haven't seen for 30 years, and my juniors are like, whoa. So all that is probably very similar. And we spent a lot of time then speaking about very, very immediate operational issues. Have we got enough oxygen? Have we got enough kit? Have we got enough? Right now it's hemofiltration. PPE is always an issue. We have never run out of anything, but it's much too much hand to mouth. And one of my commitments to the organisation is, hey, I think there's going to be every model I look at tells me that the numbers of patients coming back and presenting with COVID will increase in the autumn. And therefore, we must have a much more sustainable supply chain. And that's probably something for everybody listening to this call who's involved in procurement or finance. We've got to have loads of alternatives of sourcing kit, PPE, blah-de-blah. We've just commissioned another big tank of oxygen for our main site, which just gives us so much more resilience. But, the fact that we were, having to really work very, very hard to, my finance director is brilliant. He got that, he was negotiating with the British Oxygen Company chief engineer sort of thing. It's mad, but we shouldn't be in that position. So lots and lots of lessons, I guess. So on the one hand, my daily rhythm is, lots of calls like that and just making sure that we've got enough of everything and that we can see ourselves through. But more recently, probably in the last 3 weeks, we've been spending our time thinking much more around what next. A tendency not to want to call the programme the recovery programme, because of course that implies you go back to what you used to have. And we're never going to go back to what we used to have, partly because actually we've learned some fantastic new ways of doing business. So we're, our footfall into the hospitals for some things is so low, it really worries us. So we're not seeing, there's a load of unmet demand that we're really anxious about, but we're also not bringing patients in unnecessarily for diagnostics or outpatients. We're doing loads of stuff virtually and using Attend Anywhere. And that's the stuff you really want to capture, isn't it? And it makes there's a whole sustainability argument there, which is really powerful, and hopefully people will kind of be behind. So I don't want to call the next phase the recovery program. We can't work out what the name is for it. I don't know if you've got one in Leicester.
No.
But it's like, what's going to happen? The NHS will look very, very different. So there's something about how on earth do you stand services back up? So I'm spending a lot of time now thinking through both the next couple of months, but then also to the future. London's doing a lot of planning across the region. We've obviously spent a lot of time thinking about the Nightingale facility. Well, I'm sure you have as well. But we our thinking had to be quicker because, of course, the virus was first in urban areas, and so thinking through kind of what next for the Nightingale hospitals. That's a bit of capacity that we could all use. We had a kind of London plan, which was all about actually strengthening integrated care systems, but also bringing together specialist services on tertiary sites like yours and mine, increasing intensive care capacity. Because actually, one of the things I've been really struck by, and I quite like your view on this, is when you look at a graph of intensive care capacity in the UK compared to European numbers, we are about 50% below the European average. I think it's something like 6.6 beds per 100,000 in the UK. I think the European average is 11 point something. I think Germany is at like 20 point something. And you just think, oh my goodness, of course. So I could, people won't be able to see you nodding and smiling, Sanjay, but I can. And I think that's really quite, I didn't know that. I'm embarrassed that I didn't know it. I do know it now. And I know that our strategy needs to be to really increase the both ventilated and non-ventilated intensive care capacity for patients, not just for another pandemic, but actually so that in winter I will never have to keep cancelling patients who need surgery because my ITU is too full up. There could be a different future. So that's a really good bit of learning for me in London. And then the other thing I was going to say just about the future is, of course, when you look at hospitals in other countries that have managed this in a different way, they treat infection very, very differently to us. So patients are separated, PPE is worn in a different way. It's just normal, and I think there's some learning there for us. And I think, just thinking through, even I was walking around one of my hospitals yesterday and thinking through, God, the infrastructure just isn't right. The way we separate people at the moment is a mess, and we're using like black and yellow tape to keep people away from it. Oh, it's awful. So we're going to have to really think very, very hard about what the best world-class infection control arrangements are, and what we need to do. And I think healthcare delivery organisations like ours are going to just look a bit different. Do you have the same sense up in Leicester?
Oh yeah, totally. So I think let's say the physical plant of a hospital, I think we've learned quite a lot, haven't we, from this? So, for instance, my intensive care unit, at the moment, with the expanded capacity, we've essentially walled it off into it's equivalent to 5 different intensive care areas. Mm. So each time we go in, we have to don and doff. And of course, it was never previously naturally designed that way. So we've had to put up false walls, which means we don't have the ventilation in the areas that are walled off, which means it's a bit like an oven working in there. Yeah. And there's no windows, and there's no, so there's no natural light, etc. So all of that is very different. I just wanted to get back to your point about intensive care beds. So in the past, I did my training in the United States, and there, pretty much every ICU bed was a single bed that was walled off from the next patient, actually. And the ITU capacity was much greater. Whereas in the UK, many of our ITUs are still a bit like, the traditional Nightingale wards, not to be confused with the Nightingale hospital. So, but that's evolved over time, hasn't it? And so, this is one of the other areas I wanted to talk to you about. Is we have a health service that is built on just in time rather than just in case. And I think we've all had to reset to the worst case scenario, which is what we're living through at the moment in the pandemic. And I suppose the big question for the health service and for society as a whole is, do we need now to need to redesign our system for a just in case scenario? Because this is now fresh in our memories. The tension is always going to be the cost of it, because actually to have, one-to-one rooms and walled off rooms and, a stock of, bazillion pieces of PPE and ventilators that you're possibly never going to use in your lifetime again is a big question, right? And, you and I know that ICU sucks money from the system. It's the most expensive part of the pyramid of healthcare. So I think as a society, we're going to have to really sort of think through, but this is all fresh in our memories. So I suppose the question is, can you have both? Can you somehow reduce the cost of it, but equally make sure that we never have a situation again where we have to build an emergency hospitals? I don't know the answer to that question.
I think that's a great phrase, and I think it absolutely captures this issue that there's no contingency in the system wherever you look. So that thing I was describing about the kind of the hand-to-mouth PPE thing, and the contract we have with our staff to keep them safe, all that stuff. So I think we need a really big question with society. But of course, we never look at something in isolation, do we? So if we were going to build a just-in-case system, you'd have to do it at the same time as having a kind of very different conversation with our citizens and the public about actually what services they access in hospitals. So I've noticed that, A&Es in populations where services were a bit more integrated and things like advanced care planning were a bit more advanced, actually the whole conversation has been much easier, and we haven't admitted quite so many people to ITU where we couldn't make an intervention to help them, but we've had a different conversation about how those patients are treated, sometimes palliative care, sometimes actually just less interventionist. So I think there's a whole rounded conversation that we need the politicians to get into, and it's probably our different professions starting that off, isn't it? Because you need the accountants and the economists and the managers and the doctors and the nurses all need to start talking about this stuff. But you kind of think, what would you want for yourself? What would you want for your family? And I'm really clear that if I was really struck, Sanjay, by what a lot of my colleagues know quite a lot of Italian doctors, and the thing they all said to me was, okay, the Italians ventilated everyone. I mean, I'm exaggerating for effects, but that was one of the issues. And they ventilated a lot of people that really didn't benefit from it. And that's why we saw those harrowing pictures on the telly. And it's why we kind of all, just were like really, really anxious. Just even 8 weeks ago, we were so anxious about what was going to happen. And actually it hasn't quite been like that. And I think the medicine we practice in this country probably is a little bit different. And I think the conversation we might have next might be a bit different as well. And that's for all sorts of reasons, isn't it? So I think we can't just have a just-in-time case. And if you think about, last time I looked at the national waiting list, there's, nearly 5 million people on that list, probably a few more now. I mean, I actually don't know how the waiting lists are going to settle after this period, but, my own organisation's just got the most enormous waiting list with loads of people waiting very, very long time. Some of those people may be waiting for things they don't want anymore. There'll be some choices there, won't there? And I think we just need some quite structured, honest conversations with the public about kind of what next. Have you got Nightingale in the Midlands?
In Birmingham, yeah. I don't know if it's being utilised, but just on that last point, if you remember, I think, Caroline, early on when we did some work together about patient decision tools and value, there was a whole bunch of work that I think NHS Right Care had done about actually the conversation with patients about what do you actually want, and how that conversation is is held, if you like. It's all in the messaging. And so what I found, for instance, when I've been speaking to patients about doing tests or not doing tests or having a treatment or not having a treatment, in an elective way. So I treat people with interstitial lung disease and lung cancers. And actually, when you frame it in terms of, well, if you come to hospital, there's a risk of this condition and, contracting it, all of a sudden the conversation's different. And it's interesting in terms of risk aversion, if you like, and the balance that the people and patients are taking now. And perhaps one of the good unintended consequences of the pandemic is that we're perhaps better used to having these conversations whereby, as much as we don't like to think of it in this way, maybe we did have a kind of a paternalistic kind of attitude, and we just did things, and we sort of told patients that this is the pathway, this is what you should have done next, etc. But now we're much more likely to ask them and give them the kind of discuss with them the risk and benefits. And so I think that's a sort of a good unintended consequence. And actually, I wanted to ask you a couple of things about unintended consequences. So I think you and I and others have both sort of realised that the good unintended consequences have been things like working from home, doing virtual clinics, really asking the question about whether certain procedures are necessary. We monitor people to the nth degree for nodules and other things, and maybe we should be pulling back a little bit. So I think they're all the good. But any bad unintended consequences of all of this, would you say?
I think the biggest one for me, Sanjay, is just until recently, it felt like people were scared to come into hospital, and our A&E attendances and our admissions for non-COVID conditions were just tiny. And I look back over the stats, and where were those people? And then then I talked to clinical colleagues. I was talking to a friend of mine who's a cardiologist yesterday, and she said I saw a patient come in for an angio, and it was so much more complicated. So someone who tested positive for COVID said it was really complicated because actually the disease, the underlying disease, was much, much worse, and so it was harder just to do the procedure. And then we had to do it in full PPE. And I've seen angios done, and I was just imagining how it's just a delicate procedure with all that clobber on. Actually, it's really hard, isn't it? So we have to think about all that. So I think late presentation of some quite severe disease is going to be a real issue for us. I think we have really noticed as a system if you like, the kind of social and public health issues. So, clear rise in domestic violence, unknown conversation about vulnerable adults and vulnerable children and what's happening with them, and probably a lack of stats, actually. And so stuff happening in communities that actually is really regrettable, but counterbalanced a bit by actually communities being a bit more connected up as well. So, on the one hand, you hear these great stories about people really reaching out and 700,000 volunteers and all that. But then there's this hidden cost that probably won't surface in a way that we can get our hands around for a while. And so we're going to have to find ways as a system of reaching out to people and reaching out to the vulnerable people that we do know about, and trying to find people that we don't, the kind of sort of the known knowns and known unknowns and all that stuff. So that's quite difficult. But I see my primary care colleagues thinking about that, and I see social care thinking about that. And one of the benefits for me actually has been I spend more time with other parts of the care delivery system, thinking through the population. So our ICS is suddenly working in a way that I couldn't have dreamed of 2-3 months ago. It's amazing, and it's probably the same in where you are. And we've got to hold on to all that, and some of it is we've provided brilliant mutual aid to each other. So, oh my God, this hospital needs ventilators, this hospital needs CPAP machine, this, all that stuff. Or someone's run out of PPE. Although we've had less of that in London, actually. It's really interesting. I've been on quite a lot of national WhatsApp groups, and I notice that, the tension, particularly in areas that aren't so urban and condensed, where you can get the logistics are just a bit easier. And you think, oh gosh, that's a real thing. We've got to hold on to the mutual aid And really, I think the thing I was saying before, we just got to really sort our supply chains out and have multiple supply chains and a UK domestic base. I'm convinced more than ever that our manufacturing base needs to, really sort of stand up. So it can't all be Burberry.
So just on that, so the sort of the good things that have come out of this, how are you in your organisation going to hold on to those good things and build on them, if you like? So, for instance, for me, my choice, it's the IT thing. So our IT has, been enormously helpful, but I think it could be even more helpful going forward. So I don't know how my trust is planning to do that. And other things like cross-skilling staff, repurposing staff, using or integrating with primary care and just more integrated care, working across the care system. The fact that you are able to lend each other kit, for instance, how do we actually make sure that we don't let that go? I mean, and do you have a group of people in your hospitals now working on it, or is there just not a headroom at the moment to do that?
Yeah, no, we do. So, I said, so we got this weekly rhythm, but then this daily rhythm. And then on a weekly basis, I still have my group executive committee, which is basically the senior leadership group. And we meet and we talk about what the conditions of recovery are and how we would stand up services. And we think a little bit more long term, and we preserve that time deliberately to do that stuff. Whereas the daily calls are very, very operational. And then my ICS also has a group of people looking at recovery, and I'm the SRO for that. And I think there are, and then we're also thinking at a London level about what the conditions for recovery would be. And it's things like, capture the digital stuff like you've just said. So, attend anywhere. You've got to make that the mandatory go-to first port of call for, a consultation. People are talking about things like, gosh, is now the time to think about a different model of A&E? So actually in some countries, patients don't go to A&E until they've been triaged either by a phone system like 111 or by primary care. So would that be one way of maintaining a much better segregation of, particularly for managing infections. So there's a bunch of quite big thinking going on, and we've probably had a bit more headspace than everybody else. But this too will come to pass. But really, and then the other thing for me is with the ICSs, shouldn't we just have some really strong expectations of how they're going to work? So, one ICS should have one set of corporate support services. One ICS should have a pathology network that serves it, or why is anybody doing pathology separately? We should have a payment system which provides the right incentives for new models of care and shouldn't be transactionally based upon institutional trading, but should be based on the system. And probably in the first year, you make it really, really simple, because one of the things that we've really noticed is whilst we've had financial control and we've had governance, it's been very, very different. It hasn't been transactional. It's been making sure everyone's safe. It's been making sure we're not getting fleeced ultimately. And it's been making sure that, just stuff happens. And it's about saying yes, not saying no. And everybody in my finance team, their first instinct is to say yes. What can I do to make this happen? And that's what we've got to capture. So I think that's really important. And then I think there's this thing of how this really interesting tension we have. So you were talking about, we've got to talk to patients about what they want, but at the same time, we know that one of the biggest issues we face in Western medicine is about variability in care. And so you and I have worked before, haven't we, on standardizing stuff and taking variation out. So how do we do that and have the patient conversation about what you want in your treatment? It's difficult, isn't it? So I suppose it's and creating, it's not the illusion of choice. It is real choice. Do I want this standard pathway, which might result in me, being ventilated and may or may not have an impact and probably be a bit horrible, or do I actually want to go home and, have a completely different treatment? It's difficult. So, so I think, so to your point about kind of recovery and whatever, I can't call it recovery, the new NHS. So we create space for that. And, in fact, in a couple of weeks, I'm going to have a go at kind of virtual workshop with my senior team to see if we can kind of just make sure that the strategy that we had before probably needs a bit of resetting, because I think there'll be a much bigger play on specialist services for me and a much bigger play on ICSs. and then actually we're starting to step down some of the immediacy. So the daily hourly thing is becoming a couple of times a week. Is that the same in your organisation?
At the top of the organisation, I can't tell you, but I think because we've gotten into a rhythm clinically, for instance, on the ITU, it feels like we don't need to communicate quite as hard and as frequently as we have been, which can be grueling in and of itself. So, you mentioned WhatsApp, and I think everybody has probably got 20 more WhatsApp groups than they ever used to. And they sort of, there's a constant churn. And I think what I've noticed is there's slightly less churn in the last couple of weeks as people have gotten into a rhythm. They feel less panicky and more kind of comfortable with what's going on. So I think, and people are starting to think about, okay, well, how are we going to manage the next couple of months? How are we going to restart in my unit? It's cardiac surgery. How's that going to happen? And it's nice actually to be able to think about the future in a way that we probably couldn't even think about, a few weeks ago, I think, for me. So another question I had for you, Caroline, is the emotion of it all. So I think you and I have been talking about perhaps sort of transactional logistics, but emotion. And I think that for all of the whole workforce, we all as humans, process all this stuff differently, don't we? So are there any sort of, top 3 or 4 emotions that you've had through this? It's probably an impossible question, but...
Oh, no, it's a really easy one. So I think my partner's a psychotherapist, so this is like home turf for me. So we've put in place a lot of psychological support for our staff, and it turns out my organisation was unusually blessed with psychologists and psychiatrists and a few psychoanalysts and some therapists. So we cover the whole spectrum, and so we sort of developed a kind of graded a thing where actually... I think some of the best interventions have been where the psychologists just go and talk to teams as they're switching shifts and people just download. And then last week, there's a project called Project Wingman, which some people listening to this will know about, which is basically cabin crew, pilots and cabin crew are all grounded at the moment, but the airline industry is a safety-based industry and it's based on good decision-making and clear leadership. And so they've got this thing called Project Wingman where they come into hospitals and they set up what they call a first class lounge, and they kind of offer tea, coffee, a friendly ear, and they do it in their uniform, so it's quite nice. So it attracts, it's kind of niche, but that's kind of that's probably at the lighter end. And then we have kind of mental health first aiders and stuff. So and for my leadership group and for me actually, I think I would say we've got the same range of emotions as everybody else. Personally, I have felt frustration a lot more than I thought I would. And I've been genuinely quite angry about some of the supply chain things because I just think we should never be in this position. So which is also quite motivating. But then I don't have a lot of anxiety. I'm not a particularly anxious person. I practice mindfulness. I have for years. And, so that stuff is quite important. I've been eating less well than I normally would. All our meals are free at the moment. And, which in itself has lots of unintended consequences. But you can't get near food, so I've just been eating crap. It's that sort of thing. So I'm trying to get back to a bit of a balance. I keep saying this, right? I'm going to start the couch to 5K again. I used to run. Haven't been doing that. And I was quite unwell actually a couple of weeks ago. I think I had the virus. And in fact, so and my family did. So I've just found it quite difficult just to get that lung capacity back. So I'm sort of quite on it. And while the weather's still nice, the sun's still shining in London. Is it in Leicester?
Yeah, it's beautiful. Yeah.
And then music. I wanted to ask you about music because I know that you're doing a spot of DJing. So are you still doing that?
Yeah, so the show still goes out on a Friday night, and I pre-record the shows, but I've not been able to really have the time to do it. So one of my colleagues at the station is actually, I shouldn't really say this, but they've recycled a bunch of my older shows for the next 2 or 3 months. Actually, but I still enjoy it. So one of the things I do with a mate at work is we just send each other each day a music video of a band that we like or a great performance or whatever. And actually, I've set that up with a couple of people, and it's really it's for me that's really a way of chilling out, actually.
You like a bit jazz, don't you?
Yeah, I love the jazz. And so, yeah. Well, here's a serious question, actually, is that I kind of feel that in healthcare, although it's difficult as it is with looking after patients and personal risk, if you like, is society. And excuse me. And what I really worry about going forward is how society is going to recover. And so jazz musicians, actually, and I've been thinking about that because we promote gigs in my local area in Leicester. We get people to come and play at some of our venues in Leicester. And of course, we've had to cancel all of those gigs. And, the livelihood of the musicians, for instance, as one particular group, but, the livelihood and the economy for people who've not been able to work, or even if they can start working again, they're just going to be absolutely kiboshed. And so that's, I don't really necessarily understand or know or can think about how that's going to impact healthcare and us as humans in a bigger society. It's troubling, actually. I don't know.
It's really troubling, isn't it? Because we haven't attended to society as much as many of us might have wanted to, and now we have a government who I always imagine their instinct is around economics, but they're having to pay attention equally to the impact on kind of human behaviour and societal pressure as well as the economy. I listened to Margaret Atwood on the radio yesterday morning, and she was brilliant. She was actually talking about the fact that there's been a kind of renaissance in reading amongst younger people to kind of sort of kill time, I guess. And then she was talking about how as we reset, actually, our whole relationship with wealth and with the planet is going to be completely different. And that's actually potentially a good thing out of this, that people might recalibrate and think quite differently about, what those things mean. And that's quite profound for me. And I do actually think, it's really interesting when you hear people like Chris Whitty talk, the Chief Medical Officer, or the Chief Scientific Officer, Patrick. They're both talking about the economy as well. They both can see the need to balance and not to just take a purely scientific, very narrow view. You have to take the whole view. I heard. Oh God, who I can't remember who I was listening to last night, but they were talking about the need to probably have more kind of behavioural scientists in government at the moment, talking about exactly what you're describing, to get the balance between the economists, the doctors, the scientists, but actually in terms of human behaviour, what is it going to be like, and how are we going to build a new society which actually is more reflective of what we'd like. And I don't know how old you are, Sanjay. I'm 51, I think I am. But kind of like, so I grew up in the 70s, and I grew up in a sort of an era actually where we did talk quite a lot about kind of collectivism and kindness and equality, and equality of wealth more. And that's it's different now, isn't it? We've kind of gone through sort of 30 years of global capitalism, and people are different, and generations coming behind us are different. So I don't know. I have a slight. There's a Welsh word called hiraeth, which is like a yearning for the past, and I have a bit of that, and a bit of maybe we'll get back to something a bit fairer.
Well, I think that's true, and I think people are going to sort of reevaluate their lives, what they want for it, what's important. Hopefully people will be, I think, more kind than they ever have been. And I think that's going to happen. And actually, one of the things I've been sort of, again, really worried about or thinking about is the workforce. And before all of this happened, we had a workforce crisis. And I suppose my worry is that people who are currently working in the NHS, they'll get through all of this, the peak of it, and then over the next couple of years they might think, well, actually, if they're able to financially, or cut back. And so how we staff and the new models of staffing with extended practitioners, be it radiographers or nurses or whatever, I think we've got to go full throttle now and plan for that, and be potentially commissioning universities and colleges, because I think that's on the horizon.
Yeah, I'm sure that's right. There's a counter view that says actually that we're going to have such enormous unemployment that actually the labour market might be a bit better and might be more in our favour. But I think we have to do all the things you said and have a policy of kind of digital first and taking the need for some services away. But then I think we will be employing more people for sure. I think that's right. And we can't do some of the stuff we were talking about before around managing services safely unless we do that. So it's a very, very different future. And that some of this is so political, isn't it? And these are huge choices our politicians have to make. And you can't help thinking, blimey, this lot have only been in power for 10 minutes, and then the Prime Minister goes off sick. It's really difficult stuff, isn't it? Whatever your political views, actually, this is a most unenviable task. But I want us to play in it. I hope the HFMA will play a bit of a part in helping at least frame the arguments. I think our job might be around framing and contextualising and putting facts into the debate where we have it. And I imagine that we'll work. I love it that you're a trustee, because actually it's really important for us to have that clinical voice. And I hope we can get some economists in and sort of, help contribute to the debate as we go forward. I think it's a really big role for us.
Yeah, no, likewise. So I think probably, do you think we've been chatting for 45 minutes? Do you think people might be bored of us? Yeah. So I suppose I don't know how we should finish off. I suppose would it be useful to ask the question, how have you grown, if you like, during all of this, if you have?
Physiologically, I lost half a stone. I put it all back within. I had anosmia, which is a new word for me, but I lost all my sense and smell when I was poorly, and I lost a bunch of weight. And then literally within 2 days, I could suddenly taste. And I made a shepherd's pie for the family for 2 lots of meals. I ate a lot myself, so anyway. But I think I've got big girth, which is going to go in the next month or so. I have. I think I've. This is going to sound awful, isn't it? But the humility one feels when one sees what one's colleagues are doing, and it is actually people like you, so at risk of embarrassing you, but I'm not on the front line. I do a bit of portering and cleaning and stuff, but I'm not there. And actually, I wouldn't be very good at it either. It's kind of the thing I've realised. But hearing those stories and sitting with people and understanding what their reality is, and then holding that somehow, and being able then to play it into the wider conversations about, what next, how do we recover, and to really think about that. So I think I've my understanding and respect for my colleagues just knows no limits at the moment. And I think I've also learned that actually most of the job in management and leadership is to get out of the way. We've reorganised the hospitals with me doing very little apart from giving permission, right? So the doctors totally reorganised their rotas with just a nod. And that's the real thing for me, is most of what we do is encouragement, thanks, praise. Very occasionally there's a bit of management, but really the thing is to get out of the way, give people permission, empower them, and then they grow. And that's how we grow. And my board's done that for me. So I think that's the thing, get out of the way. Listen and get out of the way. How about you?
Yeah, so I think so all of those things are true, and I think it's understanding the team. And so what I've realised is that every member of the team has just got a massive role. And you get ideas from all quarters, and it's just about letting people having the time and space. And we always knew this, and we knew that was the right way of being in a team and managing a team. But I think I've seen it blossom, and that no one person could ever have all the answers, and actually the whole team coming together and giving people space to organise, that it is possible. And that actually also cutting away a lot of the kind of permissions and the regulation has been just liberating, actually, to allow us to do all of these things so quickly. So I suppose for me going forward, I would just want to keep on doing the same with the people I'm working with, I suppose.
Yeah. So cut through the bureaucracy, simplify the future, be part of a lovely team. Yeah.
And humility, as you say.
Yeah. Sanjay, I can't wait to see you in the flesh. It's going to be a little while yet,
Likewise,
I think.
I know.
I hope everyone listening is healthy and wise and growing and psychologically, if not physically. And see you all on the other side, eh?
Take care. Thanks, Caroline.
Bye.
Bye.
Many thanks to Caroline and Sanjay for sharing their conversation and giving us all a bit more to think about as we look ahead. The HFMA is providing regular podcasts throughout the pandemic, covering a range of areas, so if there's a particular aspect that you would like to hear about, then please let us know. All of our COVID-19 related briefings, blogs and news articles are openly available on our website, hfma.org.uk. There is no need to be a member to access these, so please share with your colleagues. We have launched a forum where finance colleagues from across the NHS can discuss issues and challenges in a safe space. You can sign up via the link in the network section on our website at hfma.org.uk. Thank you for listening to HFMA Talk. Don't forget to subscribe to this podcast to keep up to date with new episodes.